Welcome everyone to the Animal Heartbeat, your veterinary podcast. No, start it. I forgot the name of our podcast.
I thought you forgot the name of the podcast then. Should we do that again?
The Heartbeat? Yeah. Should have had more coffee. Welcome
I'm definitely
everyone.
going to leave that in.
Welcome everyone to the Animal Heartbeat, your veterinary cardiology podcast. I'm Jose Novomatos, and I'm here as always with my cardiology buddy, Kieran Bourget.
Hello.
Hi, Kieran. We have a bit of a different topic today, isn't it?
We're going to cram a whole species worth of cardiology into 1 hour. It's ambitious, but I think, cardiologists are ambitious people, right? That's okay.
Absolutely. I have to say straight away, I'm a bit out of my depth today, so I hope I don't say anything or ask anything stupid. So we'll be talking about equine cardiology, and our special guest today is Professor Colin Schwarzwald. Colin is a professor of equine internal medicine and cardiology at the Vetsuisse Faculty in Zurich, a fellow of the American Society of Echo, and the director of Equine Internal Medicine Clinic and the department chair. I met Colin more than 10 years ago when I was, a young resident in Zurich. And
young, naive baby.
Exactly, full of dreams. And I have to say, I was always very impressed with the very high standard of care of equine cardiology that Colin and his team had in Zurich. Was very, very impressive. Colin, thanks for joining us today. Welcome.
Yeah, thank you very much. It's a great pleasure to be with you today and to talk about equine cardiology. You put a lot of pressure on there to cover everything in 1 hour, but I'll do my best.
I think we can draw comparisons. I think we can focus on the interesting things.
Very good.
Maybe we could start with heart murmurs, Colin, if that's all right.
Yes, of course.
Functional heart murmurs. How common are functional heart murmurs in horses? And can you give us some tips on your clinical exam? How does a functional heart murmur sounds like, or how would you try to differentiate a functional from a pathological murmur?
Yes, so functional murmurs indeed are fairly common in horses. Well, heart murmurs in general are very common in horses, and the older they get, the more often we hear heart murmurs, but especially the functional to differentiate functional murmurs from pathologic murmurs can be fairly difficult. In fact, generally, if we have very athletic horses, maybe younger horses, and we hear either a soft systolic murmur or an early diastolic murmur, oftentimes like a squeaky murmur, then we conclude that it's most likely functional heart murmur. When they get louder, more coarse, or more holodiastolic instead of just early diastolic, usually we think it's a pathologic murmur. That doesn't mean that they're clinically relevant yet. We can have murmurs where we think they are pathologic, but they are clinically not that relevant, at least at the point in time when we see the horse. That's oftentimes it's actually difficult to really differentiate based on auscultation, and it takes a lot of experience to do that, as probably also in small animals.
Something that we will be talking a lot is exercise and the effect of exercise on your clinical exam findings, which I think is really cool and very different from what we do in small animals, that you assess a dog at rest and then you exercise the horse and we'll be discussing that in a second about the arrhythmias and so on. But do heart murmurs change under exercise? Do you, if you auscultate the heart murmur, do you exercise the horse and see how the heart murmur changes, or that's not useful?
In the old days, people said, well, if the heart murmur disappears or if it occurs during or after exercise, it's more or less relevant. I think it's not that easy. And there can be functional murmurs like ejection murmurs, meaning basically turbulent flow in the great vessels. Maybe you cannot hear them at rest, but you can hear them immediately after exercise, and they're still completely normal. It's a normal finding. On the other hand, for example, an aortic regurgitation, which is pathologic, can be heard at rest, but maybe not during or not after exercise anymore, because diastole is much shorter at a higher heart rate, and then you just simply cannot hear the murmur anymore. So in this case, the murmur would disappear, and if it is pathologic. So I think you really have to look at each individual case and think about what could be going on there. There is no general rule to say, well, if it disappears or if it appears after exercise, it's more likely to be physiologic or pathologic, at least not in my head.
And thinking about these heart murmurs, obviously in most dogs, I would tell people, if you hear a diastolic murmur, there's pathology there. There's significant pathology there. And that's completely different, isn't it? When I used to work at a university teaching hospital, I used to teach the students that if you listen to horses, you really understand diastole. You can hear the diastolic sounds. You can really time those murmurs. And that's a huge difference to dogs and cats. Day to day, we don't really think about diastole when we're auscultating. In terms of focusing on those diastolic murmurs, what are your concerns? What are your differentials for the diastolic murmurs in horses? And how do you approach that? Let's say somebody at a vetting maybe hears a diastolic murmur and says, I have a question about that. I'm not sure that that's a filling murmur. What's your advice to them?
Well, if you're really not sure, I would certainly advise to do an echocardiogram or refer the horse to a hospital or a clinic or ask an expert to visit the horse and do an echocardiogram. I think, as I said before, these early diastolic squeaky type murmurs, especially in younger athletic horses, they are more likely to be physiologic, and they're more like mid to end or holodiastolic murmurs. They're more likely to be associated with aortic regurgitation. And that's pretty much the main differential, because stenotic murmurs or valve stenosis is exceedingly rare in horses. So when we hear a diastolic murmur, and I'm primarily talking about left-sided murmurs, it's pretty much aortic regurgitation till proven otherwise. And that can actually be of great concern, because aortic regurgitation in the long run can trigger ventricular arrhythmias that can be potentially dangerous. So whenever I hear diastolic murmur, especially a mid to end or holodiastolic murmur, I want to be sure what I'm dealing with.
And so, if you echo these horse and you detect aortic regurg, how do you assess or determine severity on echo of that aortic regurg?
Yeah, I'm going to add to that question, especially when your echo views are more limited by the window than they are in small animals. We would maybe, look at the pressure half time of the aortic insufficiency. We might do a VTI, a velocity time integral of that aortic insufficiency curve. That's very challenging in horses. Am I right in thinking that?
Absolutely. That's challenging, and that's not currently what we routinely would do. Maybe I would like to make a step back and actually talk about the findings of our physical examination, because I think particularly in horses with aortic regurgitation, that's really helpful. That's what I always tell my students. In some cases, you don't need an echocardiogram to actually get a fairly good assessment of a horse with aortic regurgitation. So if you have let's say an older horse, that's a typical case, an mid-age to older horse, pretty much normal physical examination, but you can hear a holodiastolic heart murmur on left side of the chest, grade, let's say 3, 4, 5, 6 out of 6. You can be really sure this is a aortic regurgitation. So the next thing I would do, assess the quality of the peripheral pulses, facial, for example. If I can feel a hyperkinetic pulse, that would automatically mean that the left ventricle is enlarged. The stroke volume is enlarged. There is volume overload. That would also mean, if there is a large left ventricle, that there is a higher risk for ventricular arrhythmias. In other words, just by examining the horse, listening to the horse's heart, do a proper auscultation, palpation of the peripheral pulses and pulse quality, I can make a lot of conclusions. And when I have a mid-age to old horse with a diastolic murmur, hyperkinetic pulse, that's when I would tell the owner, the client, that there might be a risk for ventricular arrhythmias, and the horse should be examined further by echocardiography and stress electrocardiogram. Then, when we actually do the echocardiogram, that's where we really try to grade the murmur or grade the aortic regurgitation. And as you mentioned before, it might be slightly different compared to the small animals because of the limited views and image planes we can get. But one thing we certainly still do is just a conventional receiving chamber analysis. So we look at color Doppler imaging. We look at the jet of aortic regurgitation during diastole. We look at the size of the jet compared to the left ventricular outflow tract. But this is just a very crude estimate of severity, because there's a lot of factors that can influence your color signal: direction of the jet, settings of your machine. It's very critical. If you turn up your gain, you can make your jet much larger. If you turn the gain down, then it's going to disappear.
This is the dial-a-jet phenomenon, isn't it? Where we dial the jet up or down based on the color gain. Yeah. And so then the next step is to actually look at chamber size and function. And same here, we look at the receiving chamber. In the case of aortic regurgitation, we would primarily look at the left ventricle and assess left ventricular size and function. And if the left ventricle is enlarged, usually we have more like a hyperkinetic function in most horses with moderate to severe aortic regurgitation, but still the ventricle is large and volume overloaded. That would let us conclude that there is at least moderate, if not severe, disease. In some horses, the ventricle is, they can have a fairly loud murmur, but the left ventricle is normal in size. Systolic function is normal. The ventricle is not hyperkinetic. Also, peripheral pulses are not hyperkinetic. That would let us conclude that it's probably mild disease at this point in time. I've always considered this degenerative aortic valve disease that we see in horses as analogous to degenerative mitral valve disease that we see in dogs. In terms of, in dogs, we see this heterogeneous disease course. Some dogs will progress much more rapidly over a couple of years. Others will die with the disease in its early stages, having had it for some years, rather than experience a guaranteed progression in their natural lifespan. Do you feel the same way about this disease in horses? Is that something that you see? And if so, what are your markers of risk for progression? Do you understand how to look at a horse that has maybe a relatively normal left ventricular dimension and function, and you can say, well, actually, I have some concerns here which make me want to see the horse a little sooner, or make me a little more proactive in following this case?
Yeah, that's actually a difficult one. I agree with you that it's very similar probably to dogs with mitral valve disease, and it's really hard to predict the natural course of disease. Of course, if the aortic valve is severely altered in some way, thickened, or maybe we have a tear of one of the cusps, then that would mean that the horse is more likely to progress to more severe disease and eventually maybe go into heart failure. But oftentimes we don't see these like very obvious changes to the valve, or at least not in a way that we would be really worried in this particular case. And then it's quite difficult. Obviously, if we have it's a difference. If you have a 5-year-old horse with a severe aortic regurgitation, then we think that it's less likely to be like age-related degenerative disease. It's maybe more likely either some congenital malformation, which is not that common either, probably, or maybe some non-bacterial valvulitis related to maybe some viral disease, viral infection, or immune-mediated disease. Usually at the time when we see the horses, we don't find any signs of systemic inflammation anymore and no sign of viral infection anymore. So that might have been like months or years back. But when we have really young horses with severe disease, that's where I get more worried, obviously. If I have, like, let's say a 20 or 25-year-old horse that has had an aortic regurgitation for years already, maybe well known, and has been stable for many years, then I'm really less worried that it's going to progress really fast. And it's certainly true. There is many horses out there with aortic regurgitation. They live a long life, and at the end, they die for some other reason.
It's always very cool to listen to like 20, 25 years old patient. There's like, I saw a 12-year-old cat yesterday. It's just
I was just wondering, is there some sort of formula? Could we work out a calculation? This would be an interesting publication to see if we could get it past the reviewers. A formula working out owner's age minus horse's age. And if it's less than 0, if the horse is older than the owner, than the rider, it's probably going to survive long enough for it to be okay. Or some formula like that. We can't really do that in cats.
Yeah. And so let's say that then you echo your horse and you diagnose moderate to severe aortic regurg. And you mentioned before ventricular arrhythmias. So what is then your approach? What do you suggest the client, the owner, to do next? Do you halter them? And so what is your thought process and how do you manage these cases?
Yes. So when we just talked about progression of disease, we were thinking about, heart failure, congestive heart failure. But the other really important problem is ventricular arrhythmias. And that's where the safety issues comes into place. And that's also a difficult one. And if we have a horse with moderate to severe aortic regurgitation, the ventricle is large, maybe hyperkinetic, then we would certainly recommend a halter, ECG, 24-hour halter, and even probably more important, stress electrocardiogram. And there, obviously, we look for ventricular arrhythmias. These can be just single VPCs. These can be couplets, triplets, runs, or even short episodes of ventricular tachycardia. Then obviously we would look at signs for like more malignant ventricular arrhythmias. And that's actually not that well defined. But obviously if we have a really high heart rate and we see, let's say, worst case R on T phenomenon, or oftentimes we see something that is very close to R on T, but not quite yet, but almost there, then we get worried. And then it's a question of talking to the owner about potential risk of collapse and sudden death, which unfortunately can happen anytime. So the horse does not have to show any signs of exercise intolerance or heart failure. It can just happen anytime. And we had horses with, we thought, moderate AR, and the horse died suddenly a month after the exam. I don't say that all the horses die suddenly when they have AR, but it does happen. We don't have really good indicators to predict the risk. And then what we usually do when we find ventricular arrhythmias during exercise, and maybe it's also a question, when do they occur? Is it like at the warm-up phase, at peak exercise, or more like the cool-down phase? That might also influence our decision. But then at the end of the day, we have to talk to the client about potential risk. And it really depends on who the client is or who the rider is. I think if it's a really valuable sports horse ridden by a professional rider, he or she might be willing to take more risk. Certainly, if it's a really good rider, a professional rider, he or she will probably also feel when the horse is, not doing right, and maybe just a few seconds before the horse would collapse, they would maybe feel it. If this is a 12-year-old child who just began riding like half a year ago, that's different. Very inexperienced rider will probably not feel that something is not right, and suddenly the horse is collapsing. So we would always tell people that the horses should, if at all, should only be ridden by informed adult riders who are aware of the potential risk and who are willing to take that risk. We would not advise to use horses with, let's say, moderate to severe AR and ventricular arrhythmias. We would definitively not recommend to use them as a riding school horse or to be used for children.
And I think this is one of the massive differences in the job of an equine cardiologist versus a small animal cardiologist. Because if one of my patients suffers sudden cardiac death, it's very sad. There's a lot of grief. For a 70-kilo dog owned by a 60-kilo owner, there's inconvenience. There's all the drama associated with it. But it's highly unlikely that the animal dying will lead to the owner dying. That would be a very strange set of circumstances. In your line of work, that's completely different, right? The stakes are much higher.
Absolutely. I mean, probably the pasture horse, the retired horse,
the lawnmower
is similar to your dog. And, people then sometimes ask, well, that's the risk is too high. I don't want to ride the horse anymore. Can I just turn it out on pasture? I would say yes, absolutely. I mean, if the horse is in congestive heart failure, that's probably a different story, because these horses they're suffering probably. But if the horse is not in, yeah, it's a welfare issue. But if the horse is not in heart failure and just has this severe AR and arrhythmia during exercise, well, the worst that can happen is that the pasture horse is going to die suddenly while running around with his pasture mates. And there's worse ways to die worse for a horse, I think. So, if people want to do that, I think that's okay. The risk assessment, it's what I always tell people, dealing with horses is a risky business anyway. So it's not that if you have a healthy horse, you have no risk to die from an accident with the horse. And when the horse has AR, the risk is huge. It's higher than normal, but the risk is, there is some risk anyway. Horse business, riding horses, dealing with horses is fairly risky anyway.
That's a good point. But just exactly what Kieran said, what I think is very cool about your job, which we have nothing like that, is indeed you are working with sometimes with elite athletes, with horses that are competing at a very, very high standards. So it's similar to sports medicine in people, and to make the call if a young athlete may do high intensity sports and that kind of stuff. I think that's, well, again, a huge respect for you guys, because the decisions are certainly very, very tough to do. But it's so interesting that you are dealing with these elite athletes competing at very, very high levels. They are pure machines. And then you need to decide, okay, is okay for this horse to compete and so on. But I really liked what you said about the rider and the experience, that they will have a different feeling about what might be happening with the horse and so on. That's very cool. Very, very cool. Yeah.
Yeah, there's just a lot of factors we have to take into account. Yep.
We were talking about mitral regurg, and mitral regurg is our bread and butter. Is what we see every single day.
That's what pays for the echo machine. Is mitral regurg.
Exactly. And so, how come it's mitral regurg in horses? And again, a bit similar to the aortic regurg topic. How do you approach this case? How frequent it is, and what's your thought process around mitral regurg in horses?
Yeah, I mean, aortic and mitral regurgitation, these are probably the top two diseases we see almost every day in our horses. And some people say aortic regurg is more common. Some people say mitral regurg is more common. I think it depends a little bit on which population you look at, but both are really common. And so similar to aortic regurgitation, mitral regurgitation usually is a age-related disease, degenerative valve disease. We more likely see it in older horses. If we see it in younger horses, similar to AR, we think it's maybe valvulitis, non-bacterial valvulitis. We can get, obviously, bacterial endocarditis as well, but that's not that common. So most likely mid-age to older horses, degenerative valve disease. We are slightly less worried about mitral regurgitation because the consequences are not that potentially dangerous to the rider. Because what happens with mitral regurgitation, it's not the left ventricle primarily that would suffer from it and remodel. It's in the first step, it's the left atrium. And if the left atrium is enlarging, is undergoing some remodeling, what you can get is atrial arrhythmias. And atrial arrhythmias are not that dangerous. The worst thing that can happen is that the horse will develop atrial tachycardia or atrial fibrillation, and that's not something horses usually die from. They said there are certain circumstances where atrial fibrillation is worrisome, absolutely, but usually not this to the same extent as aortic regurgitation and ventricular arrhythmias. It's more difficult to do like just a clinical assessment. So what I've said with the hyperkinetic pulse, that applies to aortic regurgitation. That doesn't help with mitral regurgitation. So if you hear a left-sided systolic murmur, and you feel it's not just a functional murmur, it's probably mitral regurgitation, we would usually recommend doing an echocardiogram. And there are certain criteria also related to, obviously, clinical signs, but many horses, they don't show any abnormal clinical signs. So often it's an incidental finding that you hear a systolic murmur. And then there's some criteria that if it's just a grade 1 or 2 out of 6, you would not necessarily have to do an echocardiogram. But if it's grade 3 or louder, we would strongly recommend doing an echocardiogram. This obviously would imply that the grade of the murmur relates to severity of disease, which is not always true, not completely true, but it gives you just a rough guidance.
You've got to start somewhere, haven't you?
Yeah. And then with the echocardiogram, we basically look at, again, the color Doppler imaging, the flow mapping, and look at the jet size in the left atrium in relation to the left atrial size, which again is influenced by many factors and machine settings and gain settings. And then we would also look at size of the left atrium. And as soon as left atrium is getting from its normal oval shape to more round shape, and it's getting larger and more turgid and really enlarged, then the larger it is, the more worried we are. And sometimes in really severe cases, we don't see a lot of color anymore on color flow mapping, but the left atrium is huge. And that has to do with pressure equilibration. So in the really severe cases, sometimes you hear murmur, but you have problems really finding a large jet, but the left atrium is huge. That would then imply, obviously, you have severe disease.
A couple of times you've mentioned valvulitis, and that's really interesting. I don't think that's well described in small animals, although I've seen a couple of cases now where they've maybe presented with systemic signs, immune-mediated disease. I remember one collie dog some years ago with signs of immune-mediated polyarthritis. And we'd seen a few of these with endocarditis, with bacterial endocarditis. So we often incorporated valve checks in these dogs with murmurs. And on auscultation, it sounded like a flow murmur. We echoed the dog, and actually the aortic valve didn't look vegetated, but it looked thick. quite symmetrically thick. So we were very worried because we thought, well, are we going to immunosuppress this dog, or is that a good idea in this context? And I'd never really heard of this idea of a valvulitis before, a sort of immune-mediated syndrome. And we treated with doxycycline. There was an improvement in the clinical signs a little bit. The valve lesion didn't change. So then we treated with steroids, and the valve normalized and the dog normalized. Is that something that you see commonly, or are these the zebras, not the horses, the rarities rather than the common things?
It's actually not that well described in horses either. We need to be clear about that. It's not that we always, can make a diagnosis and be sure that it is valvulitis or has been valvulitis at some point. But most of us think that, as I said before, if it's younger horses, let's say 3, 4, 5-year-olds, it's hard to justify like that this is a age-related degenerative change. So then we think about, well, what could it be? And many of these horses, they are at young age, as yearlings, they're out on pasture with many other horses, and many of them will undergo some viral infection at some point, and maybe people don't even recognize it because they're out there in the field, and maybe they're just not doing well for a day or two, and then it's over, and nobody will ever take a temperature and realize that the horses actually were sick, or maybe they're coughing for a while, and then it's okay. And so it's more like we think that it happens, and I mean there's some reports out there that show that, but how common it actually is, and if our suspicion is always right, we don't know, or I don't know at least. And sometimes the clients, they will report, oh yeah, like half a year ago the horse has been coughing, had a fever, had some respiratory infection, and a few months later the veterinarian recognized the murmur for the first time. Then we will conclude, well, that could be the origin or the etiology. In many of the horses, we don't have that type of history. So you ask the clients, has the horse had a fever? Has the horse been coughing? And they don't know about anything. But still, if it's a really young horse, and if it's a new murmur, then we think that that's what it could be. And bacterial endocarditis, this is a systemic disease. So horses with bacterial endocarditis, they are often younger horses, and they're often or usually systemically ill. They can even have lameness of unclear origin, synovitis, polysynovitis.
Right, that's interesting. Yeah, we see that too.
And recurrent therapy-resistant fevers, and that's when we would think about endocarditis. Yeah.
Still talking about murmurs, Colin, something that I came across recently was the concept of training-induced tricuspid regurg, which is something I was not aware of. And we talk a lot about in dogs about athletic hearts and some breeds that are more athletic, and we don't really know how to define athletic hearts and so on. So as you deal with elite athletes, it would be very cool to get your input on that. So maybe first, what is training-induced tricuspid regurg? How do you assess the severity? Is that ever a problem? And if you could tell us a bit more, which changes do you see in the heart of an athletic horse?
Yes. So, I mean, in general, athletes, they have, physiologic hypertrophy of the heart, primarily left, but certainly right ventricle. And you can see that. I mean, if you echo in a really athletic horse and then you echo a completely non-athletic pasture horse, you will immediately see the difference, particularly in relative wall thickness, maybe also systolic function. If you go into more advanced technology, you might pick up some differences in systolic and diastolic function, although it hasn't been that well described yet, I guess. But you can see that. And in regards to murmurs, yes, absolutely, it does occur, tricuspid regurgitation, but also mitral regurgitation. does occur, and the incidence will increase with training. My explanation usually is that there is a change in the anatomy and geometry of the valve and the valve apparatus, meaning papillary muscles and chordae tendineae and mitral valve and tricuspid valve annulus. Due to this change, there might be trivial to mild regurgitation. Another factor might be that horses during exercise, they develop fairly high pulmonary pressures. So that might be another factor coming into play there, so that we really see tricuspid regurgitation fairly commonly. It even led us to recommend that horses with a right-sided systolic murmur. The right-sided systolic murmur, it's either a tricuspid regurgitation or a ventricular septal defect. But we think it's a tricuspid regurgitation. We would tolerate a grade up to 3 out of 6 without necessarily recommending an echocardiogram. This is particularly true for athletic horses and race horses. I think my interpretation or clinical assessment of a right-sided systolic murmur in a warm blood horse is slightly different. So if I have a warm blood horse with a grade 3 out of 6 right-sided murmur, I will probably also do an echocardiogram. If it's the classic well-trained racehorse, I will probably tolerate it and conclude that it's probably training related and not clinically relevant. Some people call it physiologic. I'm not sure whether it's really physiologic. I wouldn't necessarily call it a physiologic murmur or a physiologic regurgitation, but it's usually harmless. It's not clinically relevant.
Okay, that's cool. Just because you mentioned it, I cannot let it go. Kieran and I are very interested on pulmonary hypertension and so on. Do we know why some horses develop, can I call it exercise-induced pulmonary hypertension? Why does that happen? Do we know what the mechanism is? And can you give us some thoughts on that, please?
Yeah. So as far as I know, and I'm by far not the expert in when it comes to pulmonary hypertension, but my understanding is that horses have a dramatic increase in cardiac output during exercise. I mean, just looking at the heart rate, a resting heart rate of 30 would max to a heart rate of 200 or 220 during high-speed exercise.
It's crazy.
So that's just phenomenal, and cardiac output will increase dramatically, and pulmonary vascular resistance will not decrease to the same extent. So automatically you get an increase in pressures there. So I think that's at least when it comes to exercise-induced pulmonary hypertension, that's the mechanism as far as I understand. How much hypoxic vasoconstriction maybe also plays a role, especially in horses where lung function is not perfect. Maybe horses with inflammatory airway disease, equine asthma, that might be another factor that comes into play.
Thinking about training-induced murmurs, just really briefly, because there's a lot more we want to talk about in terms of atrial arrhythmias, I know. In humans, there's this identification of training-induced arrhythmias, and there's some data out there to support it in dogs where they had treadmill exercise to a very high level, and a proportion of them develop ventricular arrhythmias after a period of intense training. Is that something that's on your radar for horses, or are they just too highly evolved as athletes that actually that's not a problem for them?
Well, I think the problem we have actually, we know that horses, even apparently healthy horses, when they undergo training and when they're racing, they will show arrhythmias, supraventricular, ventricular arrhythmias. But up to date, we don't really have a good idea what is still normal and what is abnormal. I mean, everybody has some kind of rule of thumb what is still acceptable and what is not acceptable. Obviously, there is some, findings like, as I mentioned before, if we have like runs of ventricular tachycardia with near ROT or even true ROT phenomenon, that would not be, or it's hard to imagine that this is normal. But other than that, if you have an EPC or some couplets, and is this still within normal limits or not? We don't have really a good idea about that. But it certainly does happen that even athletes they can develop a fair number of arrhythmias during exercise and after exercise. It's not always considered pathologic.
Super interesting. When I think of horses and equine cardiology, I think of atrial fibrillation. Now, that may be because my involvement as a cardiologist with horses has largely been cardioversion for these cases. So just outline for us the importance of atrial fibrillation in horses.
So atrial fibrillation is a very important rhythm disturbance, and it's considered the most important when it comes to exercise intolerance and poor performance. Because atrial fibrillation will, no matter what, it will decrease your exercise or the horse's exercise capacity. Not all riders will actually recognize it or feel it. The same here. If it's just a pleasure horse being used to ride in the woods, maybe the rider will not feel it. If it's a racehorse, it's never going to win a race. So it is absolutely, it is important. And in the old days, we thought that atrial fibrillation is not a dangerous rhythm. I still think per se, atrial fibrillation is not dangerous unless the onset of atrial fibrillation is during high-speed exercise on the racetrack, for example, where a horse can collapse when there is a sudden decrease in cardiac output. So that can obviously be dangerous for the rider. Most horses are not going to die. But there are horses out there with atrial fibrillation. When you exercise them with an ECG, you can see that the heart rate really increases to really high numbers. So normal maximum heart rate is around 220 beats per minute. Horses with atrial fibrillation can go far higher than that. So up to at least instantaneous heart rates or very short periods can be in the 300s.
And that's because it lost that priming function of the atria. Is that correct?
Probably, yes, probably. But there can also be like ventricular arrhythmias on top of the atrial fibrillation. That also happens. 2 years ago, we published a consensus statement about cardiac disease in athletic horses, and we kind of gave or tried to give some guidelines. When should we be worried? And we kind of concluded that when the heart rate in an exercising horse with atrial fibrillation, if the heart rate exceeds the limit of 220 beats per minute for multiple beats, then we should be worried. And the second thing is when we see wide complex arrhythmias. So, atrial fibrillation should not give any wide complexes, any wide QRS complexes. And sometimes during exercise, we see that it's not just atrial fibrillation, but we have wide QRS complexes. And they just have a different conformation. They're wide, and oftentimes we don't really know for sure whether it's just aberrant conduction in the ventricle or whether these are additional ventricular arrhythmias on top of the atrial fibrillation. If the rhythm is getting very regular during exercise, so you have wide complexes, really narrow, really short coupling interval, and they're really regular, I tend to conclude that these are ventricular arrhythmias. If there is still an irregularity, because atrial fibrillation should never become completely regular. So if I see wide complexes and they're still irregular, I conclude that it's more likely to be aberrant conduction. And if on top of that you see again ROT phenomenon, then we get worried about potentially sudden death in a horse with atrial fibrillation. There's at least one horse where this has been documented by ECG, so that the horse had atrial fibrillation during exercise and then went into ventricular fibrillation and died.
Some years ago, I published a paper looking at sudden cardiac death, or suspected sudden cardiac death, I should say. Thanks, reviewers, for dogs with atrial fibrillation. And the way that we did it retrospectively. I mean, it's hypothesis generating, of course. But we identified the prevalence of sudden cardiac death in dogs with atrial fibrillation was about 14%. And in dogs with a matched cardiac disease profile, but with sinus rhythm, they had about 4 or 5% sudden cardiac death. So the prevalence was different, but actually, even looking at halters, we couldn't identify predictors of sudden cardiac death in that population of dogs, apart from a younger age at diagnosis, really, and a history of syncope. So whether that's the dog going in and out of AF, or whether there's ventricular arrhythmias there, or, I mean, it was a messy population, and it's hard to tease out treatment effects with that data. But it's an interesting concept, because reading around for that paper, in humans, just being in AF reduces your threshold for ventricular arrhythmias. And there's data in dogs, again, experimental data, that if you put a dog into AF, you can trigger VT and VF much more easily if they're in AF than if they were in sinus rhythm, irrespective of whether they have underlying heart disease or not. So it seems like the AF itself is a substrate for ventricular arrhythmias. I'd be interested in your thoughts on that, and whether that's part of your risk profiling. It sounds like it is.
Yeah, I mean, that's at least our way of thinking. Yeah, absolutely. That the risk of ventricular arrhythmias is increased in horses with atrial fibrillation. And it's also interesting when you convert them back to sinus rhythm, then you exercise them, you see far less of these ventricular beats, or sometimes they disappear completely. So there seems to be a relationship between AFib and these ventricular events. Yeah.
How do you assess these guys? You see a horse today in your clinic with atrial fibrillation. It seems to me, based on what you said and what I read from your consensus statement, that then you want also to see what the rate, the ventricular response rate is during exercise. So is that generally your protocol? Do you assess a horse, and then you exercise them to see what the ventricular response rate is? Or there are some cases where you say, no, this is straightforward, we need to treat this horse?
Yes, so generally, we tend to recommend treatment in all horses that are still used for some athletic activity. Because we think that it's always better to have a horse in sinus rhythm compared to atrial fibrillation, even if it's just a pleasure horse or dressage horse. I mean, a dressage horse can probably still win the tournament, but even if it's an AFib, but it probably might do better in sinus rhythm. So generally, if the horses are still being ridden or used for some athletic activity, we would recommend.
So independent of the heart rate, independent of the ventricular response rate.
Yes. Yeah. But then, sometimes people, owners, clients, riders, they need a little more to decide. Because obviously treatment is somewhat risky, treatment is expensive. They really want to know, do we really have to treat the horse, or is there a way around it? And some owners also say, well, I can reduce the level of exercise. I'm happy to do that. So if I can use the horse with atrial fibrillation, but at a lower level of exercise, I'm happy to do that. So I don't need treatment. Then we would usually go ahead and do an exercise test and exercising ECG to look for the criteria of potential malignant events, meaning heart rate over 220 beats per minute for some period of time during maximum exercise, wide complex arrhythmias, RNT. If we see that, any of it, then we would strongly recommend treatment.
When do you make the decision about pharmacologic cardioversion, and how do you go about that versus electrical cardioversion in these patients?
Yes, I think nowadays we have a lot of experience with both treatment methods, medical, meaning quinidine, or electrical cardioversion. So I would say the majority of horses nowadays we treat electrically. Doesn't mean that quinidine is not a good choice. It's just it has a different. I think it's a slightly different population where I would use it. I mean, the young racehorse with paroxysmal atrial fibrillation and at some point it doesn't disappear, so you have to treat it. Oftentimes you just give them 1, 2, 3 doses of quinidine and they convert and they're fine afterwards. It's probably less expensive overall to do that. So I'd be happy to do that. Even in a warm blood horse, if it's like short-term atrial fibrillation, the horse is clinically healthy. The horse does not have a really high ventricular response rate during exercise, doesn't have any wide complex arrhythmias during exercise, doesn't have any severe underlying disease, is not in heart failure, I would still go for quinidine. But there is certainly horses where I do not like to use the quinidine. These are the ones where when they have a increased ventricular response rate at rest or during any stressful situation or during exercise, if I see wide complex arrhythmias during stress or exercise, I don't like the quinidine because I feel that these are the ones that then also show adverse reactions with quinidine treatment. These are the ones where we see really high ventricular response rates during treatment. These are the ones where we potentially see ventricular arrhythmias during medical treatment. There, I'd rather go for electrical cardioversion. And for the long-term or longer standing atrial fibrillation, we also tend to maybe choose electrical cardioversion as opposed to quinidine. But I've seen both. I've seen horses that were, we failed to convert them using quinidine. A few weeks later, we were successful using transvenous electrical cardioversion, and the other way around. I've had horses where we were not successful using TVEC, and the week later, we were successful using quinidine. So I think both are still good options.
That's interesting. A
bit of not controversial, but more something that we have a lot of no data at all is the use of antiarrhythmics before trying to electrical cardiovert a dog in these guys. Is there any data in horses? What's your protocol? Do you pre-treat horses with amiodarone or other drugs to try to increase your success of electrical cardioversion? What's your experience on that?
Yes, so if I do electrical cardioversion, oftentimes we pre-treat these horses with sotalol.
I am so pleased you say that, because when I used to do this, we adopted that policy for nothing other than, we might do it in dogs, and it made us all feel better.
Yes, absolutely.
Now I can say, well, we were doing the right thing, because that's what Colin does as well.
Yeah, right.
Colin said.
That's completely confidence-based and not evidence-based. So we don't really know how much the effect, the effect is on success of cardioversion and reduction of recurrent AFib. We don't know. We feel that it might make a difference, but we're still not sure about that. Personally, amiodarone, I don't use it. I know that people use it, maybe not so much for pre-treatment, but if they are not successful during electrical cardioversion, they creep up the energy level and they reach the maximum energy level and they're not successful cardioverting them, they would add amiodarone on top of it and then try shocking again. That helps sometimes. We don't use it. Also because it's fairly expensive in our hands, at least here in our country, and usually I can go without it.
So, and if you see a horse today, again in your clinic with AF, do you give it like 1 or 2 days to see if this could be paroxysmal AF, and then also if you start sotalol, for how long would you give sotalol before you try to cardiovert them?
If I see a horse with atrial fibrillation and I know it's just recent onset, I would wait a day or two. Absolutely. And some horses really, they convert back to sinus rhythm spontaneously, especially horses with idiopathic atrial fibrillation, what we used to call lone atrial fibrillation. But then after 1, 2, 3 days, it's unlikely that they would convert spontaneously. Then we should consider treatment. I would not wait too long with the treatment because of potential remodeling, like AF-induced remodeling that then stabilizes the arrhythmia. So if possible, treat as quickly as possible. As for the pre-treatment with sotalol, we usually go with, if possible, 2 days before TVEC. If that's not possible, at least 1 day, or we would start the evening before the TVEC, before the procedure, and then continue afterwards. That might be a difference between the quinidine cardioversion and the electrical cardioversion. With the quinidine cardioversion, at the time of cardioversion, you still have quinidine on board. So you still have an antiarrhythmic agent on board that would prevent immediate or early recurrence of atrial fibrillation. With the electrical cardioversion, you don't have that. So, you shock, you get sinus rhythm, and that's it. You don't have, per se, you don't have any antiarrhythmic agent on board that would prevent immediate or early recurrence of atrial fibrillation. And that's why we give sotalol. That means we would continue the sotalol after the cardioversion for at least a few days, oftentimes even longer, in an attempt or belief that we could reduce the risk, the recurrence rate.
Do you have feelings on recurrence rate in the horses that you convert? How frequent do they recur, and what you do next? You shock them again? What's your approach?
Yeah, so I think so. In the average patient population, we see the recurrence rate is about 30%. So it's fairly high. That's certainly, or might be different in young racehorses with paroxysmal AFib, where maybe other factors play a role. Recurrence rate might be lower there. But in the average population we see, which is mostly warm blood horses, it's at least 30%. And I'm talking about horses with, what we call idiopathic AFib, where we don't see any clear structural underlying disease. As soon as we see, let's say, mitral regurg and a slightly enlarged left atrium, we tend to go higher with our prediction of recurrence rate, and it's more like 40 or 50%. Also, if a horse has had AFib before, has been treated, now has a recurrent episode of AFib, then the risk of yet another recurrent episode after successful treatment is much higher, obviously. So can we treat horses multiple times? Yes, we can. I've done that. Horses that came back every few years, sometimes shorter, have been cardioverted, successfully cardioverted multiple times. Many people, many owners, however, they give it a try. We tried once, maybe, or often, far more than 90%. We're successful with the cardioversion procedure. But then when the horse has recurrent AFib, they oftentimes decide not to try it another time because they obviously know or are informed by us that the recurrence rate is at least as high as it used to be, if not higher.
In people with these refractory atrial fibrillation histories, especially in the absence of structural heart disease, they might be looking for a focus, maybe a focal atrial tachycardia, maybe these rotors that are hypothesized in the pulmonary veins in people as triggers or originators of the fibrillatory activity in the atria. And they might look for ablation as a technique there to try and deal with these. What does the landscape look like for that in horses? Is this something that we can do? And what are the considerations for ablation and electrophysiologic mapping in horses?
Yeah, that's now a really interesting topic. If you ask, can we do it? I would say no, but yes, there are some groups that can do it. And nowadays it's primarily the group at the university in Ghent in Belgium. That's my good friend and colleague Gunther van Loon and his fantastic team up there. They have been developing the technology and procedures for electroanatomic mapping and ablation in horses. I've sent, I guess, 4 or 5 horses up there already to undergo the procedure. And that's indeed something that is worth considering in horses with primarily idiopathic atrial fibrillation that have recurrent disease. As you said, this can be, very frequent APCs, or they can go into atrial tachycardia before then they end up in atrial fibrillation again. Or some horses also, they present with atrial tachycardia. And, there, if we diagnose atrial tachycardia as opposed to atrial fibrillation, nowadays we would not even try treating them with quinidine or electrical cardioversion, because we know that the rate of recurrence is even higher than in atrial fibrillation. So I've seen horses with atrial tachycardia. I've sent them up to Belgium, to Ghent right away for the mapping and ablation procedure. The other place where this technology is now being developed is the university in Cornell in the US. This is Kath Mitchell and her colleagues. Kath was actually one of our PhD students here in Zurich before she went to Cornell. And she is now developing or introducing these procedures in Cornell as well. To my knowledge, these are the only 2 places at the moment worldwide where electroanatomic mapping and ablation is being done in horses.
I think that's super interesting. From the work by Roberto Santilli and his colleagues in Milan and also at Cornell. Santilli works both sides of the Atlantic. He's just an overachieving guy. The data they're finding about dogs is really, really intriguing. And the landscape there is quite different to human. And I suppose there might be future application or greater application, because I know they've done it for ablation of ventricular arrhythmias as well in these patients. And that's really interesting area for development, isn't it?
Absolutely. I think it's actually interesting in 2 ways. One is what you just mentioned, also treatment, ablation. But I think it's not less important is to learn to better classify arrhythmias based on surface electrocardiograms.
Right.
Because, how many times are we sitting there in front of a Holter ECG and we don't know whether the horse is in sinus arrhythmia or has APCs? We don't know whether this wide QRS complex is just because of some bundle branch block or aberrant conduction, or whether it's a ventricular premature beat. So many times we're just lost, and the common criteria of deciding whether it's supraventricular, whether it's aberrant conduction or VPC, they don't always apply. There's a lot of exceptions, and there's a lot we still don't know. And there, I think the electroanatomic mapping will be very helpful in the future. Hopefully also to better learn to correctly diagnose arrhythmias based on surface ECGs. And so far we have primarily done just base apex lead ECGs, or maybe just 1 lead or 3 leads. But nowadays people have started doing 12 lead ECGs in horses, something that for a long time has not been done because people thought it's not helpful. Well, we think nowadays it is helpful, especially if you want to go to a mapping and ablation procedure, because you have to know where to put your catheters. Is it the right heart or the left heart? Is it, you have to know where to go. So that's what we are also learning now, that the 12-lead ECGs might be really helpful.
And it's interesting because I remember speaking to Peter Dark, who is, one of the fathers of veterinary cardiology, canine, feline, equine. Years ago, I remember him standing up at a meeting and correcting Gunther van Leeuwen and saying, actually, I published that in the 1960s as part of my postdoctoral fellowship at the University of Bristol. And There was an intake of breath across the audience, and Gunther was
Yes.
very gracious, as he is. He's a lovely guy, and
Yes.
was very, oh yeah, that's super interesting. Let's talk about this some more. But I think Peter's work back in the late '60s. Now that we're more interested in the endocardial mapping and actually considering the idea of ablation, suddenly that research from 60 years ago, 50, 60 years ago, becomes much more relevant to us again. And that's interesting, isn't it?
Absolutely. I think we forgot some of the really old data and just haven't taken it into consideration. And nowadays we realize, oh, this has really been, or important and it's really good data. And Peter Dark, same here in Zurich. There was a older colleague called Spurry. He was well known at that time, and I think in the 60s, for his cardiovascular research, but people have forgotten about him. And there's a lot of old data out there that probably becomes more and more interesting again with the current procedures we're doing. Yep.
But that must be the definition of a legend, right? What a legend. You do some research, and then 60 years later, people go back to your research and recognize that was important.
Yes.
That's amazing.
Like Van
That's
Gogh.
really amazing. Yeah. Maybe to finalize our discussion, Colin, we have been talking about mainly tachyarrhythmias, ventricular arrhythmias. We should just briefly touch on AV blocks, as they are also so important in equines and is also a bit different from what we see in dogs. So vagal induced AV blocks. Can you also guide us again on your clinical exam, and going back to the clinical exam? On your clinical exam, you detect a potential AV block in a horse. How do you go along to exercise this horse to see if the AV block disappears? But what I also wanted to know from you is then, are you then not worried anymore, or are you still worried even if the AV block goes away during exercise?
Yes, I would say in 99% of the cases, I'm not worried at all, because AV blocks are completely physiologic in the vast majority of horses. Even if you have two AV blocks, and I'm talking about second-degree AV blocks, if you have two second-degree AV blocks in a row, this is still considered physiologic. If I just see every once in a while, every few beats, single AV block, I probably wouldn't. I don't even think about it. It's normal. If the horse is sedated with alpha-2 agonists, even more, they develop AV blocks. If I'm not sure, I would not necessarily do a stress ECG in every horse. I might just, circle it in the stall or walk up and down and see what happens. Heart rate goes up just a little bit, AV blocks disappear, completely normal. If I see two in a row, maybe, I do a little more. I stress them a little bit, circle them, trot them up and down, see what happens. If I'm still not sure, I would do an exercising ECG and see what happens. For sure, if I have 3 second-degree AV blocks in a row or more, this would be considered pathological. And if that happens, we would certainly have a closer look at the horse, and we would certainly want to know what happens during exercise. If, let's say, I have a horse with 3 or 4 second-degree AV blocks in a row, so high-grade second-degree AV block, and they disappear during exercise, completely disappear, I will probably feel, for this point in time, feel fairly comfortable that it's not dangerous, but I would certainly inform the client that this can be progressive disease that eventually leads to even more high-grade second-degree AV block that maybe then does not disappear anymore during exercise, maybe even complete third-degree AV block with either an escape rhythm or maybe not a functional escape rhythm. Then the horse would collapse and show signs of syncope. And, if I see that, I would certainly do an echocardiogram. I would certainly want to know, is there any structural disease? Is there any inflammation? Is there anything I could potentially treat or that could tell me what the cause is for AV block?
Do you ever do atropine tests, or exercise is a way more physiological way to assess these horses?
Yeah, we mostly do exercise. We don't do atropine tests. We are worried about colic in horses if you give them atropine, and that exercising works well. That works well.
Cool.
Yeah.
That's nature's atropine response test.
Yep, absolutely.
Cool.
Would you put a pacemaker in a horse?
Yeah, we can. We've done. They usually come in groups. So we have a long time we don't have any, and then we
do that, right?
Then we have like 3 in a row, and then we have years with nothing. So a few years ago we had a donkey and 2 horses with either high-grade second-degree AV block or third-degree AV block. All of them had signs of collapse and syncope or near syncope. All of them got a pacemaker, and that works well. I mean, it's not that challenging of a procedure. The most challenging is in horses to get pacemaker leads that are long enough. That's usually the limiting factor. If you have really large horses, there's to get leads that are long enough, that's challenging.
You just daisy chain the lead extender kits is, I guess, the way to do it.
Yeah, but even with the extender, sometimes you can only put the extender on when the lead is placed, and if you put the extender on before the lead is replaced, that usually doesn't work. So it's difficult. But the ones we had were average size horses, 500 plus minus kilograms, and it did work.
Can you still ride a horse with a pacemaker, or do you need to retire these horses?
We do not recommend riding horses with a pacemaker because there's a lot that can happen when lead fracture, dislodgement, whatever, and collapsing horse while riding. It's not a good idea, so we do not recommend it. However, we do have owners, at least one owner. She was a veterinarian. And she insisted continue riding the horse. So we put in we put in the pacemaker, and it was like a rate responsive. So during exercise, heart rate would increase. So after like a month or 2, I called her and just to ask about how the horse was doing, and she was like, "Well, the horse is doing great, but trotting and galloping up the hill, he's really slow." So we probably need to look at the pacemaker settings and
rate response curve up a little bit.
Yeah. So we had her come back and we tweaked a little bit around with the settings, and she was happy afterwards. The horse was again galloping up the hill, and she was happy.
Fantastic.
That's informed risk right there.
Yeah.
Colin, thanks so much. This has been really, really fascinating to revisit equine cardiology for us and to review things. We like to ask our guests to give us their top 3 take-home messages for the listeners about what we've discussed today. It may be challenging because we've covered a lot of ground, but what would your top 3 take-home messages for people be?
I think the top 3 take-home messages. One is certainly that people have to realize that horses have heart murmurs and arrhythmias. They can be, in many of the horses, they're either physiologic or they're harmless. They can live a long life with arrhythmias and with murmurs, with leaking valves. But there are individual horses where that's not the case. And the tricky thing is to find these horses, to identify these horses and to do a risk assessment. And I think that's the second maybe take-home message in horses. When we compare it to small animals, it's not so much about treatment. We didn't really cover the topic of treatment of valvular disease, but maybe I can say here that we are not that far as you guys are in small animals. There's very limited options for treatment of valvular disease. So when it really comes to what we do every day, it's more more likely to do a risk assessment and to advise people about further exercising the horse. That's maybe another take-home message. It's difference on difference in goal. we have when we examine these horses. Maybe the third one, this is a very simple one, but I think that's what I always tell my students, coming back to aortic regurgitation, is maybe that you don't always need an echocardiogram to make a solid conclusion about severity of disease. So that's not true for all the diseases, obviously, but aortic regurgitation is really common in horses, and there's a lot you can do just by looking at the horse, examining the horse, listening to the horse's heart, feeling pulses, pulse quality, and that's all you need. So, and there you can cover a lot already just with a good physical exam and good auscultation without all the fancy tools. And that's when it comes to experience, I guess. So don't be afraid to examine horses. If you're interested in this topic, just take every chance you get, and you'll get better at it.
Fantastic. Thanks very much, Colin. It was very, very interesting indeed. I might start trying to do some equine cardiology one day.
Don't be afraid of horses, Jose. It's okay. You might need a longer stethoscope though.
So it was a great pleasure to talk to you guys and to be with you here. And I can just invite you to visit us in Zurich, and we can echo some horses. And
I'm there. I love equine echo. Fantastic.
So that would be great. That would be great. That would be great. Colin, say hi to everyone in Zurich. I miss that place a lot.
I will. I'm very happy to do that, and hopefully see you soon.
Thanks to Colin, and thanks to our listeners for tuning in. Fantastic summary of equine cardiology. Remember to stay tuned for the next episode of season 2 of the Animal Heartbeat, and to like, share, and follow us on social media. Our handle is @heartbeat_pod.